This is Dr. Weber reading the most recent Prostate Cancer Commentary, which is on sequencing BAT with Xtandi, an effective option. Bipolar androgen therapy, BAT, has been validated as an effective but likely underused option in the sequence of treatment for metastatic castration-resistant prostate cancer. What is BAT and where does it fit in? BAT is the monthly cyclic elevation of testosterone to supraphysiologic levels, 1,500 to 3,000 nanograms per DL, by injections of testosterone while continuing ADT. The regimen leads to a durable PSA and objective response in 30 to 40% of patients, as noted in an article by Pernette in the Journal of Clinical Investigation. BAT was first described in the literature by Dr. Michael Schweizer and has been tested in numerous trials since. In the original report, BAT was given over 6 cycles to asymptomatic patients with low to moderate burden metastatic castration-resistant prostate cancer. The PSA 50 response was 28%, and PSA 50 indicates a PSA drop of greater than 50% below baseline. In 2 later trials, the PSA 50 with BAT was about 24.3%. Dr. Schweizer's research substantiated that prostate cancer adapts to low testosterone levels by upregulating the androgen receptor. In the setting of elevated androgen receptor, BAT therapy resensitizes the androgen receptor to inhibiting agents such as Xtandi, to which resistance had developed in prior exposure. The androgen receptor is, of course, the key cellular molecule that orchestrates PSA response and cancer growth and is inhibited by diminished testosterone. This essentially is the basis of BAT's effectiveness. The Prostate Cancer Commentary had presented an update on BAT in volume 161, which can be accessed here. Dr. Denhamede, a prominent researcher, along with other colleagues at Johns Hopkins, published the very informative, quote, Bipolar Androgen Therapy, BAT, a patient's guide, and the link is provided for examination of that report. The paradox: lowering serum testosterone to the desired 20 to 30 nanograms per DL with Lupron or related agents is standard anti-prostate cancer therapy. A suppressed testosterone inhibits a cell's androgen receptor signaling, which in turn lowers PSA and suppresses prostate cancer growth. It is counterintuitive and a paradox that supraphysiologic testosterone levels are toxic to the androgen receptor when the androgen receptor levels are high, the setting in which the BAT is effective. The key point to understand about BAT therapy is that BAT suppresses androgen receptor when the AR is abnormally high. During Xtandi therapy, and to a lesser extent with Zytiga, AR levels become elevated. This is the basis of monthly cycling between supraphysiologic androgen levels and low testosterone, as fully described in A Patient's Guide. And this suggests a new regimen of therapy. The Transformer trial, National Cancer Treatment Therapy 022-86921, demonstrates that BAT sensitizes the androgen receptor to Xtandi. This trial enlisted asymptomatic men with metastatic castration-resistant prostate cancer progressing on Zytiga, and then randomizing the men to next receive either BAT or Xtandi. Both continued to progression. Those men receiving Xtandi had a PSA 50 response of 25%, a response duration of 4 months, and an overall survival of 29 months. Quote, for those patients who received BAT first after progressing on Zytiga and then received Xtandi, the PSA 50 response was almost 80%, with a time to PSA progression of about 11 months and an overall survival of 33 months. This was described in the Denamide article. This finding might suggest a potential sequencing scheme, that is to say, treat metastatic prostate cancer to progression with Zytiga, initiate BAT to progression, then follow with Xtandi, or cycle between BAT and Xtandi each month, and that regimen is described later. Benefits and adverse effects of BAT, nicely discussed in the Patient's Guide, section 2.9. Benefits of BAT therapy. Quote, significant improvement was observed in areas of physical function, emotional well-being, and fatigue, unquote. Quality of life was improved in relation to sexual function, sexual desire, and sexual satisfaction, restoring erectile function in men who had been competent prior to initial therapy. Fat loss and muscle mass gains were reported. Improvement in cholesterol and lipid levels occurred. Adverse effects of BAT therapy. Generalized musculoskeletal pain and achiness, lower leg swelling, breast tenderness and tissue enlargement, and hot flashes and fatigue at 30%. BAT may cause fluid retention. Caution should be taken in use with men with underlying congestive heart failure. BAT should not be used in men with symptomatic bone metastases. BAT, the future. Rapid recycling between BAT and Xtandi. Over a 6-month period of BAT treatment, resistance develops. A potentially more effective regimen is being tested in men with asymptomatic metastatic castration-resistant prostate cancer to overcome resistance. Alternate BAT and Xtandi in monthly cycles, as set forth in the clinical trial 04363-164, called Step Up, which refers to sequential testosterone and enzalutamide prevents unfavorable progression. Trialists are men progressing on ADT alone or ADT plus Zytiga. Other regimens that include BAT with a checkpoint inhibitor, BAT with the PARP inhibitor olaparib, and BAT combined with Sulfigo, radium-223. BAT has already found increasing effectiveness in men with BRCA-type mutations. Caution, BAT should not be used in men with hormone-sensitive prostate cancer, urinary obstruction due to prostatic enlargement, and in simultaneous combination with Zytiga, Xtandi, or chemotherapy. It's advisable that BAT be supervised by an oncologist familiar with the BAT regimen, since the interpretation of PSA response is not obvious. Bottom line, BAT increases the effectiveness of subsequent Xtandi therapy and is a promising option in asymptomatic men with metastatic castration-resistant prostate cancer.